Hi everyone, we're back for part 2 of chapter 19 in coping and stress tolerance, and we're going to start with depression. So with this mood disorders, there's 3 different categories that are noted in children and adolescents. The first one is the major depressive disorder, MDD, and then the dysmic disorder and adjustment disorders with depressed mood. And the major depressive disorder is a depressed or irritable state with a decreased interest in activities in life for at least 2 weeks. This is broken down into 3 subclassifications, the first one being psychotic depression, the second being seasonal affective disorder, and the third being atypical depression. Children and adolescents with the psychotic depression have a greater incidence of adverse long-term outcomes and can be resistant to psychopharmacomedics and at a much higher risk of developing bipolar depression. Seasonal affective disorder is just as what you would think it is, more common during the fall and the winter when there's less daylight. And then atypical depression affects approximately 15% of kids with depression and is characterized by hypersomnia, increased appetite, some psychomotor retardation, and weight gain. The dysthymic disorder is characterized by a depressed or irritable mood for the majority of the days over the last 2 years. It's considered to be less intense but more chronic than major depressive disorders. And then the adjustment disorder is with a depressed mood typically occurring within 3 months after a major life stressor. This disorder involves less severe symptoms and is relatively mild and brief. So some common facts that we know about depression: there is an increased rate with age. There is a prevalence in prepubertal depression being low. We know that there can be depression in younger kids, less than 5, but it's difficult to assess truly given the limits of cognition and language skills at that age frame. The book mentions the prevalence of prepubertal depression at under 1%, but rises to approximately 5% in adolescents. And the literature further goes on to say that the possibility of experiencing depression is about 5% in early adolescence, but can rise as high as 20% by late adolescence. In the adolescent ages, there are several factors that could increase this increased risk of depression, such as hormones, social environment, academic expectations, and exposure to negative events. There's also a biological component, and these theories are used to understand how psychopharmacology helps with depression. And the first one is impaired neurotransmission, the second one is endocrine dysfunction, and the third one is a biological rhythm dysfunction. With the biological component, certain life events may trigger the onset of depression. These could include the loss of a parent or significant other, losses that accompany injury or disabilities, family dysfunction, exposure to traumatic events, and physical or sexual abuse. With early onset depression, there is the potential to switch from a unipolar depression to a bipolar depression. Some clinical findings of this are similar to an adult. You can have the irritability, mood changes, temper tantrums, withdrawal socially, somatic complaints, and behavioral problems. In males, you may see more externalizing symptoms such as aggression and anger, and in females, internalizing symptoms such as somatic complaints. As many as 1/3 of pre-adolescent children who meet criteria for major depression develop the bipolar depression. And then with depression, there can be psychiatric comorbidities, and the most common being anxiety disorders that can occur 2 to 3 times more often. Other comorbid conditions include disruptive behaviors, eating disorders, substance abuse or dependence, learning disorders, stress disorders, and ADD. And these conditions can occur with a variety of medical conditions, especially with those with a neurological component, such as a brain injury, learning disorders, migraines, and epilepsy. Other clinical findings that we may see in toddlers and preschoolers is a lack of energy. They may have a sad or grouchy mood. There may be poor appetite, weight loss, sleep problems. They may be whiny, clingy, and have separation issues. In the school-age child, there may be irritability, anger, hostility, and issues noted at school. They may not want to go to school, or there may be poor performance in school. In adolescence, there may be impulsivity, hopelessness. You may note antisocial behaviors, substance use and abuse, and aggression. It's important that when you are assessing a child for mental health issues that you interview the child directly. It's thought that more than half of depression cases are missed when only the parents are interviewed. In the book, there is a extensive list of symptoms that can be associated with depression. We're not going to go through all of them, but please review those. Those can include depressed mood, change in appetite, energy issues, self-worth issues, thoughts of death, suicide, etc. There's also a table in there talking about the warning signs for suicide, table 19-5, and I encourage you to look at that as well. On this slide, these are several depression scales that can be used in the pediatric population. To the left, you can see the name of the scale, and to the right, you can see the ages that it is appropriate for. So when working up your differential diagnosis, it's important to include review of their medications and any chronic illnesses that the child may have, such as hypothyroidism, adrenal insufficiency, metabolic disease, sleep disorders, inflammatory bowel disease, type 1 diabetes, etc., because these can predispose children and adolescents to depression. Management of depression is important at the onset to determine if suicide is a risk. It's greatest in the first 4 weeks, and like we talked about, review table 19-5. If suicide is a concern, there needs to be an immediate psychiatric referral. You need to evaluate and refer for any concerns of substance abuse. If there's been a major depressive episode, then that needs to be a referral to a mental health specialist. Psychopharmacokinetics is something that is often used with children, but use of these medications has not been included in clinical trials, and so safety and efficacy from the literature cannot always be bridged to kids and adults. SSRIs are often used for treatment along with cognitive behavioral therapy in depressive patients. And some pediatricians and pediatric providers feel comfortable managing these. Some do this in consultation with a specialist. So I would encourage you to speak with your preceptor about ways that they manage these things. Prognosis for these kids, it's chronic condition and has a high reoccurrence rate, but it's important to have close follow-up for all children and adults with depression, especially ones that have significant symptoms that need to be maintained with medication. Let's talk next on bipolar disorders. And this is an unusual shift in mood, energy, and functioning, and may begin with a manic, depressive, or a mixed set of manic and depressive symptoms. It's a recurrent disorder, and it's characterized by manic episodes that precede or follow major depressive episodes. In between these episodes, most individuals return to normal function. There is a genetic factor to it in about 60% of cases, and between 15 and 19 years old is the most common period of onset. Also, the risk of suicide is the highest in the psychiatric disorders seen in the bipolar depression population. So clinically, with an early onset, it may be more severe. You may notice irritability and continuous rapid cycling or a mixed symptom state. Late onset, there may be severe mood changes. The child may have an inflated self-esteem, lots of energy. They may agitate easily. They may have a decreased need to sleep, compulsion to talk. They may distract easily. They may be more risk-taking, more hypersexual, and they also may have suicidal thoughts or behaviors. Your differential diagnoses could include mood disorders, substance abuse, and ADHD. Management would be include referral to a child mental health specialist and mood stabilizers for pharmacologic treatment. Examples of mood stabilizers might be lithium by itself or in combination with an anti-seizure medication such as Valproex, and you could have it in combination with atypical antipsychotics like risperidone. With the use of lithium, the patient must be carefully monitored. Let's next talk about some social aggression. And this is a social behavior with intent to harm others. It could be overt, such as hitting or pushing, or it could be covert, such as gossiping. It is thought that approximately 5 to 6% of American children have behavioral problems with aggression, and 1 to 10 of the children meet the criteria for oppositional defiant disorders. Risk factors may include a history of maltreatment or parenting issues. Males are more likely to be aggressive than females, and aggression can peak during adolescence. Social aggression may also be a precursor to a conduct disorder, and it also may be considered an inherited pattern. Some clinical findings that you may see: oppositional defiant behavior in preschool, aggressive behavior such as destruction of property, name calling, hitting, biting, kicking, tantrums, lack of problem solving, bad language, and arguing. Differential diagnoses may include oppositional defiant disorders or conduct disorders. Management would include a thorough assessment of temperament and the parent temperament, teaching conferences, trying to determine what the underlying cause is, and then referral if patterns of social behavior issues occur. Let's move on now to conduct disorders. And these are repetitive, persistent patterns that violate the rights of others or social norms. The onset of this aggressive behavior may be seen in toddlerhood. Early onset problems are diagnosed from 4 to 6 years old, and a formal diagnosis is typically made around the 7-year age or older. Chronic negative circumstances can be the cause, such as harsh discipline, abuse, or neglect. Conduct disorders are seen more in males than females. Dysregulation of behaviors tends to be seen more during the transition from early to middle childhood. And part of this is there's a change in the structure and the demands of the social environment for the peer in regards to peers and school settings. With this condition, there's a high rate of comorbidity with major depression. And then with the two combined, there's an increased risk for substance abuse and suicide. And then attention deficit order can negatively influence the severity of the conduct disorder. Your clinical findings: you will find conduct disorders broken into 4 subgroups: aggressive behavior resulting in physical harm, non-aggressive behavior causing property damage, lying and stealing, and violation of rules and laws. In your differential diagnosis, you need to include ADHD, but oppositional defiant disorder is characterized more by disobedience than aggression. And then ADD is characterized by inattention and impulsiveness. So be sure and get a good, solid diagnosis. Management would include managing the aggressive behaviors before a conduct disorder develops. Once that has developed, you'll need to refer the child or family for intervention. Safety is the priority, and medication for explosive aggression may be needed, and this would be with the benefits of a referral to a psychiatric specialist. Okay, let's talk briefly about the oppositional defiant disorder, and I know that all of these can get very confusing, but oppositional defiant disorder is a negative, hostile, defiant behavior that usually occurs between 3 to 7 years old. Its etiology is thought to include issues with parenting and family dysfunction, identified with social aggression. Some clinical findings include recurrent, negative, defiant, being disobedient, and hostile behaviors. Management includes attention to early signs and symptoms, positive parenting strategies, and referral for intervention. Okay, let's move on to some eating disorders. And this is an abnormal behavior secondary to an altered body image. There can be anorexia, bulimia, rumination disorders, and this is when the child, and can even be with infants, bring back up partially digested food and re-chew it. Pica, when you're eating non-nutritional foods, and then feeding disorders of infancy. Those individuals that are athletics, middle to high socioeconomic status, possibly have had parents that divorced, have personality disorders, are at a higher risk for eating disorders. On the clinical findings, you may see that these individuals have unusual concerns on body image, as that is common in the teen years. There may be a refusal to maintain a weight of at least 85% of what the expected weight for the height and age should be. There's an intense fear of being fat, body dysmorphism. You may notice binge and purge eating. With anorexia, usually underweight. With bulimia, usually average or underweight. And history may include absent periods, preoccupation with food, weight loss, fixed schedules, constipation, diarrhea, dizziness, or sore throats. Physical findings may include altered growth around face. You may see parotid gland enlargement, fluid retention, low blood pressure, low heart rate. May see dental erosion or cavities from throwing up. There may be alopecia or lanugo, the fine downy hair on the body. Differential diagnoses could include IBD, some CNS lesions, or metabolic diseases. Diagnostic studies would include electrolytes to rule out any other causes for these elimination issues and emesis. Management would be referral to a mental health specialist. Medications may be needed. Inpatient management when weight loss is severe. Other complications include with anorexia has the highest mortality rate of all mental health disorders. Death could occur related to cardiac arrhythmias and hypokalemias. You may see alcohol and drug addictions, osteoporosis, GI disturbances, and GYN and fertility issues. With substance abuse, substance use is the beginning stage before you have abuse or dependence. You may see these kids having a maladaptive pattern of coping, and there can be significant impairment from the substance. Some important criteria to assess in children and adolescents: has there been any substance-related blackouts? Are there cravings? And are there any impulsive sexual or risk-taking behaviors associated with the use of the substance? Some contributing factors include genetics, parental substance abuse, dysfunctional family relationships, life events that have been negative, psychiatric conditions, low self-esteem or low body image, school failure, low religiosity, latchkey kid, being sexually active, homosexual or bisexual, and then competitive athletes. When you're conducting your history and physical, it's important to be non-judgmental and non-threatening. There is a questionnaire called the Kraft questionnaire that can be used to assess for substance abuse. It's important to look for behavioral signs such as decreased school performance, hypervigilance, risk-taking changes or withdrawal from friends, mood changes. Physical signs may include weight loss, red eyes, hoarseness, upper respiratory issues, accidents, traumas, intoxication, amnesia, gynecomastia, irregular periods, itching, perioral sores. Your differential diagnosis needs to include social drinking and non-pathological substance abuse. Diagnostic studies may include urine toxicology to assess for the substance. And management, the key objective is prevention is best. So using your time with your patients as educational, and then referral to a substance abuse program is essential if concerns for substance abuse are there. All right, that's the end of chapter 19. Thank you very much.